All right, we're live.
All right, good morning. It is April 21st, and this is the Senate Health and Welfare Committee. Today, we're beginning early because we have to look at a couple of things before we actually dive into testimony. And so, Katie, thank you for being here on H-171. Appreciate all the work that you've been doing behind the scenes and in the scenes and getting things firmed up for us. So why don't you just go right ahead and what draft are we on? I guess it's 4 point something. Katie, we can't hear you. No, can't hear you a bit. Huh. Nellie, is there something you can help with, or you're still muted? I tell you what.
It's her microphone on. There's a microphone on her computer.
Yeah.
Do you have a headset you can use? Do you have an iPad you can call back on?
Do you have your mute button on your computer?
You know what you can do, Katie? Call in with your phone and use your phone for your voice. I've seen other people do that. And you know what I'm saying?
We'll just hold on a sec. While Katie's doing that, I just want to say that later this morning, after we've moved through 171, we have a long list of folks to testify. And just to establish some ground rules as we get to that, I think it will be important for us today just to listen, and then we're just going to listen. We're very crunched for time. And unfortunately, we don't have time to get into conversation or ask a lot of questions. So let's all agree to do that up front. Josh, Senator Terenzini.
Just a quick question off the subject a little bit while we wait for Katie. I was told yesterday that by another senator that the way the Senate works towards the end of the session is that the morning committees often end meeting before we adjourn. Is that the case?
Yeah, so we haven't been told a drop dead date yet, but there will be a specific date, and then morning committees stop meeting, so that it allows for the money committees that meet in the afternoon to get their work done. So
Understood.
Yes, you're absolutely right. All right, Katie, are you here?
Can you hear me?
Yes.
Oh, good. Sometimes my first call of the morning, my audio doesn't sync up. So, okay. I'm glad you can hear me, and I will pull up my document now.
We're glad we can hear you too.
Okay. So this is 171 draft 4.1. As you remember, we were looking at a strike all amendment yesterday. And I've retained the highlighting for the sections the new language we looked at yesterday, and I've of course added highlighting to the things we've changed. But just to kind of refresh your memory, there weren't many changes, so I'll go through them. There's one change that wasn't highlighted because it was a strike, but in this intent language in section 4, there had been a date of October 1st, 2021 for this to take effect, and you'll see that language has been removed. And then the next change was section 10, I believe. So let me get us there. If you remember, sections 10 and 11 were kind of the two sister pair of sections that contained the ARPA language. So there was language that we talked about yesterday, that instead of having a representative of the business community, we have individuals representing a range of employer and business interests. That change we discussed yesterday. And similarly, we talked about how in subdivisions 1 and 2, we're looking not at all funding to make these changes, but at bridge funding to make these changes. Yesterday, we also talked about that we were going to have to do an appropriation for section 13, the systems analysis. It wasn't going to be coming out of ARPA because the date changed. So this change reflects the fact that section 13 has been removed from the ARPA study as something that needs to be funded. The next, okay, so next we're in section 11. This is the ARPA study that has the joint fiscal language that we spoke about quite a bit yesterday. So this is new language that you haven't seen yet. So this just restructures the joint fiscal approval. So by September 1st of 2021, the department is to submit a report to with the working group's recommendations to the chairs of this committee, House Human Services, or their designees. And the chairs or their designees review the report and recommend to joint fiscal whether or not to approve the report's recommendations. And then after review of the report and the chairs or the designees recommendations, joint fiscal committee is to shall approve the report's recommendation, disapprove the report's recommendation, or direct the department to amend and resubmit the report to the chairs by a date certain. And upon approval by JFC, the department shall distribute funds according to the report's recommendations. So there's that authority to spend once JFC has approved.
And this, Katie, you worked out with joint fiscal.
Yes, this received the stamp of approval from Catherine and Steve.
Good.
I think they're comfortable with it.
That's good.
And I believe that was the only other change in 11, yes. Section 12, we did not have any changes. Section 13, this is the systems analysis, and this is the same change that we looked at yesterday, but this is a date change that by September 1, and also a structural change. Building Bright Futures is to develop and issue an RFP to select an independent consulting entity with expertise in the field of childcare and early education to provide an analysis and recommendations on Vermont's childcare and early education system for children from birth through 5 years of age. The development of the request for proposal and selection of an independent consulting entity shall be done in consultation with the chairs of this committee and Human Services or their designees. And then we have the date that the report is due on. So this is earlier than was in previous drafts or the House draft. So this would be coming in July 1, 2022. I think the previous date had been September. So that is when the independent consulting entity is submitting the report. And then there's one new item that the consultant is looking at, and that's ensuring data-driven accountability for improvement of the current well-being and future outcomes of children and families. And then, of course, we have the appropriation we discussed yesterday that in fiscal year 2022, $200,000 is appropriated to the department from the general fund for the purpose of enabling Bright Futures to contract with an independent consulting entity pursuant to this section. And my understanding from our work in the House side and working with Nolan is that the Building Bright Futures appropriation flows through DCF, which is why it's structured this way. Then we have section 14, which is the financing study. So we have joint fiscal contracting with the consulting entity by July 1st of 2022. And then in terms of dates for when the report is coming back, we have the preliminary report coming back December 1, 2022. So that gives the consultant, 5 months with the finished analysis, systems analysis. And then in subdivision 2, we have the final report coming in January 15th. So a month and a half later, the final report comes in. And as this committee discussed last week, there will be multiple financing options for public and private funding sources, including a final report and then we have items that were already in the underlying bill. And I believe that is it for changes that this committee discussed. Let me scroll through to be sure. Oh, and the title change we discussed yesterday. That's it.
Okay. So questions for Katie. I think so being in a Zoom fog, I think we have seen most of this. So Senator Cummings, you have a
I
question?
just trying to remember, why are we waiting 2 years or a year from now to do the financing? Because that's always been the problem. I mean, why not start the financing this year?
So I think Katie can probably answer the question better than I can, but we're thinking that having the systems analysis up front and then allowing for the consultant to look at the system and then provides financing recommendations relative to that as much as possible, as well as what's currently happening. And then it also gives time for understanding the effect, if any, of ARPA funding that there's a lot on childcare in there. So Nolan, I see you perked up, so go right ahead.
No, I think you explained it well, Senator.
All right. So I think that, and that's, did we talk about that yesterday? Yeah, seems like 100 years
I
ago.
don't remember it. Okay.
Okay. Any other questions about the bill as it is right now? All right. I think, we want to make sure that we're adhering to whatever joint fiscal can do in its time. And I do think that this does a lot of good work. Thank you, Katie, and thank you, Nolan, for your good work on this. It's great. Okay, committee, any other questions, discussion on 171? I guess that one section that we have that is new, make sure you just, you look at that, but that is something that Katie and Nolan worked on collaboratively and with other members of joint fiscal to make sure we were able to move forward. Okay. Well, I am open to a motion, unless the committee would like to wait. We can wait until tomorrow. We can wait until later today, or we could entertain a vote on this draft that we've just been through. Senator Hardy.
Thank you, Senator Lyons. Thank you, Katie, for all your work on this to get the language right. And I just wanted to acknowledge what Senator Cummings said. We didn't talk about that yesterday directly, but the explanation is my understanding of it too, that why the order is the way it is. But I am ready to vote and would be happy to make the motion if everyone else is ready to do so.
I would say make a motion, then we'll open it up for discussion.
Okay. I move the passage of H171 version, is it 4.1, Katie? 4.1 as discussed this morning.
Okay. The motion's been made. Discussion? All right. Hearing none, then why don't we go ahead with a vote? Senator Terenzini.
Thank you, Senator Lyons. So this morning we'll vote on H171 draft 4.1 on April 21st, and I'll call the roll. Senator, I'll be a yes for Terenzini. Senator Hooker.
Yes.
Senator Cummings.
Yes.
Senator Hardy.
Yes.
And Senator Lyons.
Yes. Terrific. That's great. I know. It feels like a long haul. So I think the reporting piece is important. I'm happy to report it unless there's someone who is really.
Ginny, I think you should report it. This is a major bill and you're the chair.
All right. I'll report it. A lot of work has been done outside of committee, but the heavy lifting in here has been important to us, and I do very much appreciate, Katie, your work, and Nolan, your work on this. It's been very important to us. The historical knowledge of the bill's development has been particularly helpful. So we'll go ahead with that. The bill will, I think, I'll try and get it out to the Secretary's office this morning. Katie, if I have a clean copy, and then it will be referred very definitely to appropriations, and then we'll see what happens from there. Okay, that's great. Thank you all. So I don't see Nellie. Jen is coming in later on the budget memo.
She has 120 and 132 on her schedule as well, so she
Yeah,
should
she'll be
be
here
in.
soon. Okay. So just a comment on the budget memo. We'll try to finish that off later after we've heard testimony this morning on S-120. And then the other bill that we have scheduled for Friday is H-430. That's the, I don't know what to call it anymore. It's the expansion, the pseudo expansion of Dr. Dinosaur. So there'll be some language suggestions that are coming to us on H-430, and I'd like to fit that one in tomorrow. So I'm going to try and put that up on our schedule for tomorrow as well, so we can see the language. If there's any time at all today to do that, we will. That's a Jen bill, so we'll have time to look at, hopefully have time to look at it. And the other issue on S-120 is I keep getting requests for testimony, and I'm very open to hearing from folks who want to testify. So we may, I've added in some people today, so the list is actually longer than it looks. So we aren't going to get to the discussion that we might hope to. So we'll take some time tomorrow and possibly Friday on S-120, but we are up against the barrier of time, and I'm going to ask us to be very thoughtful about time and really keep from making long statements about the bill and keep from asking questions. Those are the ground rules today. I understand that we're all would like to talk forever with each one of these witnesses, and I'm one of those, but we'll restrain ourselves today. That's that. Let's see if there are any other bills. We do have other bills on our agenda for tomorrow, and I think some of them are H-210. We do have some new information coming to us. We also have others who want to testify. So there'll be a couple other people on that list for tomorrow. There may, as I said before, be some spillover on S-120, but we'll see how that goes. Please do read through the bills that we have on the agenda for tomorrow and on Friday, so we can all be together in making our decisions. And Jen is here. Okay. So Jen, thanks for being here. I think that given that it's an 8-minute window to possibly do something now on the budget memo, do you want to go through it at this point, or?
Sure.
Okay.
Just pull it up. And does Nellie have the current version? Do you want me to send it to her? Or do you
Yes,
just want me to
please, because it's not
put
on our
this up?
page.
Okay. I will do that first, and then I can still put it up in anticipation. Okay, do you want me to wait until you have it, or
If
just
you-
put it up?
If you put it up, that's
Okay.
sufficient. And then when Nellie has it on our webpage, we can follow.
Great. All right, so whoops, I scrolled down. So this is the new version. I think this is very similar to what we looked at yesterday. And oh, I am Jennifer Carby, Legislative Counsel for the record. So I've changed the date to today. It says that you still says that you support the provisions of the House budget with the revisions and additional appropriations recommended here. So I needed to make some changes to the description of H-171. So unless you made other changes to the money in that this morning, hopefully that is in good shape. It's now a recommendation of $8,229,000, of which $5,529,000 from general fund is for changes to CCFAP, 2.5 million for the provider scholarships and student loan repayments, and 200,000 for the child care and early childhood education systems analysis study. And then Katie had also thought it would be a good idea to add this note that section 5 of the bill specifies that funds for modernizing the Bright Futures or the Bright Futures information system are located in the technology modernization reserve, and that's language from the bill itself. And then I don't recall if there are any additional changes in the money. I think those have stayed the same since yesterday. And are you wanting to focus just on the changes?
Yes, I think so, because we've been through this now,
Right.
some of us many times, but I think we've been through it as a committee.
Right. So then we have the changes to specific provisions of H-439, the budget bill. The first is the DA and SSA workforce provisions, and I don't believe this has changed since yesterday. Did make I made a small change based on some helpful feedback actually from a lobbyist who was watching. In this title here, it had said nursing and primary care physician scholarship programs, but since the recommendation is to expand that, I took out the word physician up here, so it's nursing and primary care scholarship programs. And I don't think we made any changes in the specialized child care transportation piece. Blow this up a little more. Reach Up grants, I think Senator Hardy, you had noted that the funding wasn't specified in here. So I included that for the, this is under additional provisions for inclusion in the budget. Reach Up grants, the committee recommends appropriating $2,770,000 from the general fund for additional Reach Up base funding. These additional dollars then would be used to increase Reach Up grant amounts for participating families by increasing the, and then it goes into the language that had been there, increasing the basic needs standard from the 2008 to 2021 level while maintaining the current ratable reduction at 49.6%. And then that recommended language. Parent-child centers, I think there was a small number change from Senator Hardy. This is 3.75, if I'm remembering the right one, in one-time funds. And I just changed some of the language a little bit, I think, to make it a little more consistent throughout. So recommends appropriating up to 3.75 million in one-time funds to increase the funding for parent-child centers for FY22. Did not hear anything about this, the language from AHS on the all-payer ACO model, the delivery system reform and HIT language. So that has not changed. Did make a little bit of a change after our conversation yesterday around the DFR benchmark plan review. And not, I think, in the lead-in language, but in the language itself. So one of the things that I did, this is where DFR, in consultation with a number of individuals and entities, reviews Vermont's benchmark plan to determine whether to recommend asking approval from the feds to modify the benchmark plan. So I started this language now with, as part of its review, the department shall determine the potential impacts of modifying the benchmark plan to include coverage of each of the following. That had been somebody's suggestion. And then down here in the report part, DFR shall provide the results of its benchmark plan review, including the impacts of adding coverage for each of the items listed in subdivisions A 1 through 4 of this section, and any recommendations for modifications to the benchmark plan to the committees. So hopefully that makes it a little bit clearer that you're really looking to see what each of those, the impact of adding each of those would be, not just as a package.
That looks good, Jen. Thank you.
Great, sure. All right, then we have the AHS global commitment language, and I don't think that that has changed. The higher education and expanding capacity in the healthcare professional education programs. We did change a little bit yesterday to talk about increasing the number of graduates entering Vermont's healthcare and social services workforce. And also in here, using that same language, increase the numbers of graduates entering Vermont's healthcare and social services workforce, particularly in nursing, primary care, psychiatry, and clinical mental health professions. So I changed the language a little bit and got rid of some prior awkward wording I'd put in there. And then we have the findings and recommendations coming back. I'm wondering, as I'm looking at this, if this would be another good place to add the Human Services Committee, especially since you're talking about the social services workforce.
Yes. Good catch.
All right. Great. So I made that change. And then additional one-time appropriations. And I think we took something out of here that Senator Lyons, you had thought fit under existing existing provisions in the budget. And then we have the additional proposals. Yes.
So I just wanted to, is this an okay time to bring that, the milk
Oh,
bank?
sure.
Okay.
Well, let me take this.
Do you want to, is that the end of the memo?
That's the end of the memo.
That's the end of the memo.
That was the end.
That's the end. So
great. And if we need to put it, back up to make some changes to it or something, that's fine too.
Okay. So,
that,
sorry,
so
I wanted to
hold on.
Go ahead,
hold
Ginny.
Hold
Sorry.
that thought. So you have additional one-time appropriations and then proposals for consideration. So Senator Hardy, make your pitch.
Yeah. So one of the things that did not make the list that I put together in our spreadsheet last week, because it didn't come in until later, was support for the Vermont Breast Milk Bank. They emailed all of us yesterday or maybe Tuesday. Yeah, no, yesterday is Tuesday. Asking for a small appropriation. They did get $15,000 in CRF funding last year. And this is a milk bank for breastfeeding mothers. And then if there are emergency situations where breast milk is not available, there's a bank where you can go get it. As a mother who breastfed 3 kids, it's really important to me. And I was wondering if the committee would consider adding them to the list for just a small one-time appropriation of $25,000.
So you're putting it on page 7, additional one-time appropriations, $25,000 for the breast milk bank.
I'm trying to remember I think the CRF, if that literally went to them or if it went to the food bank for them, but maybe I'm thinking of the diapers.
The diapers went there. I was trying to think of the same thing.
I remember because I remember the donor milk bank.
Yeah, so, I don't know where it went, but I had the same thought, and I was like, diapers, breast milk. One goes in one. Sorry, thinking too much about it.
All connected.
So, committee, we're listening. Your thoughts on this one?
Good.
Senator Terenzini, you have your hand up.
I certainly be proud and happy to support Senator Hardy's request. I think it's important. $25,000 at the end of the day is a drop in the hat to ensure that newborns and mothers have what they need. And I think it's a good call, and let's see it happen.
Okay. Anyone against? Senator Hooker? Senator Cummings?
I'm there.
Senator Hooker, are you okay?
Good.
Senator Cummings? Okay, so I think if you put it right underneath the food bank, that might suggest a way for distribution.
Okay, and I'm going to look back and see if I can find where
Okay.
it had been in the prior bills and use some of that language. What was the amount?
25.
25. I mean, they asked for a range of money. Last year they got 15,000, so 25 seemed reasonable to me.
Okay.
I can forward you the email that we received yesterday, Jen, so you can see
That would be
it.
great. Thank you,
Okay.
because it may have some useful language just for the descriptor a little bit.
Yep.
So, you know, and so this sort of raises the whole question about all of the things that we funded with CRF. And I'm probably not out of sync when I say that appropriations, our committees and other committees will be considering the funding that we did last time moving forward. But so we haven't heard from everyone who was CRF funded. I haven't heard back from the diaper bank, but I know from the diaper folks, but I do know that the food bank is very supportive of that. And I think they're working to make sure it happens as well. So I think there are a lot of people rowing in the same direction.
And I think we put money in H315 for the diaper bank, if I
Yep,
recall.
we did.
Actually, yeah.
Jen, is there anything else we need to know?
I don't think so. I mean, let me just look at the language. If we just put in 25,000 and Senator Hardy sends me that email so I can take a little language out of it. I think that's straightforward.
And Senator Lyons, yes,
Yep.
yesterday we were listing all of the things that we wanted DFR to look at, and we sort of said eyes. We said hearing aids, dentures. They're just looking at it and getting numbers, and I wonder if we could add eyeglasses or vision
Okay.
to that list.
I'm fine with that. Jen, is that something we can put in pretty simply? Vision?
Sure. Yes, I think we'll say vision care.
Yeah.
How's that?
Good.
Thank you.
I mean, as long as it's happening and they're looking for additional items, that one does make some sense.
Done.
Excellent. Okay, so committee, Jen, can we just scroll through that one more time so we have with those two changes? Can we just look at those briefly?
Yes, except I still have to write the Vermont Donor Milk Center.
Okay, so
Right.
let's do this. Let's come back to it at the end of our testimony today. It is on the schedule for that. So we'll come back to this somewhere around 11. I have a sense that, or between 10:30 and 11. We'll do that. And just as a heads up for folks, for committee, H430. Is it H430?
Yes.
Yeah.
Dr. Dinosaur.
Yeah. So the House Healthcare Committee is going to be looking at some proposed changes to that makes it less administratively burden and possible that we can do it. And so the House Healthcare is looking at that language, and we're going to look at that language as well. As I said, probably tomorrow, if there's a way we can sneak it in. It's never snuck in. If there's a way we can put it in later today, Jen, we'll try to do that. But our goal
I
is
plan to be with you all morning. So
perfect.
whatever you want to take up at any time, I'll be ready.
Thank
Jenny,
you.
I'm sorry, what language? I missed.
There's some recommendations from DEVA that Jen has been working on with DEVA that
The Dr. Dinosaur.
would make Dr. Dinosaur. I think you're aware of it.
Yeah, I
Senator.
am. Okay,
Yeah,
thank you. I was wondering what
Yeah.
bill we were talking about. Sorry.
All right, so we'll get to that, and I think it is definitely an improvement in terms of being able to do what we would like to, what the intent is. All right, any other questions on the budget memo at this time? All right. So we're going to move on to hear testimony about S120. And I know that folks who are here with us this morning understand the the time crunch that we are under, and I appreciate the comments that I've had back from you about that. So I look forward to your testimony, and I know that many of you have testimony that Nellie is putting up on our webpage that may extend further than your comments this morning. And we will certainly read all of the testimony that we get. That's our job. But please don't make it a thesis. Thank you. So 120, and then there are sections of 132, I think, that people are commenting about. I have suggested streamlining 132 and adding some sections into 120, some changes, and I think that Jen had put my suggestions together, and I don't see them on the webpage yet, but we'll get to that. That's the
Would you like them on the webpage?
I'm happy to have them there, and I think it might help folks, all of us, because I feel responsible for 132. And if there are sections of 132 that are problematic or that people want to support that are not included in my triage, I think it's helpful to know that up front.
I will send it to Nellie.
Okay. All right. So let's move along. First, I have to have my agenda in front of me. Thank you. There we go. I'm going to go in the order of the agenda. And then I do know that there are a couple of other folks who have asked to testify. For example, Helen Laban of the FQHCs has asked to testify, and so she would be also added on to our agenda. And looking forward to hearing everyone's comments. So thank you. Lynn Stanley is, Lynn, are you here? Lynn, thanks for being here. Terrific.
I am.
So please introduce yourself for the record, and then we look forward to hearing your thoughts.
Well, thank you, Madam Chair. For the record, my name is Lynn Stanley. I am the Interim Executive Director for the National Association of Social Workers Vermont chapter. With your permission, I would like to turn it to Michelle Deneau, who will be giving our testimony today.
Fine, that's fine.
But I am available to answer any questions.
Terrific. Michelle, welcome.
Hi, thank you. Thanks very much. Good morning. Thank you for the opportunity to provide testimony as your committee moves forward on S-120, the Joint Legislation for Healthcare Affordability Study. As you know, my name is Michelle Deneau. I am an MSW candidate at the University of Vermont. I am here with Lynn Stanley, the Interim Director for the Vermont chapter of the National Association of Social Workers. We would like to bring to your attention the importance of mental health providers to both healthcare affordability and access. Per the findings of S-120 regarding the Biden administration's willingness to partner with states to pursue non-traditional reforms, we bring this proposed reform to your consideration. Over the years, this committee has acknowledged the value of loan repayment for nurses and primary care providers. We ask you now to look at the value of loan repayment for mental health providers. Is that upon graduation, these professionals must find high-paying jobs so that they can earn enough money to pay for the loans, rather than work in the areas of the greatest need, which are far often than not lower-paying jobs. Loan forgiveness would make it significantly easier to recruit and retain mental health care providers where the need is the greatest. In Vermont, unlike New Hampshire, there are no state loan repayment programs for mental health providers. There's a federal program through the National Health Service Corps, but that program is very limited and does not provide widespread loan forgiveness. The New Hampshire state loan repayment program allows certain healthcare professions, including mental health providers, who agree to work in mentally underserved areas in New Hampshire. Because the study in S-120 requires outreach to stakeholders and institutions, we think this issue could have a place right here. We would request the following amendment, and then we have submitted wording for it, but I can go through it right here. It would just say Section 2, Joint Legislation Healthcare Affordability Study Committee Report. C, Power and Duties. The committee shall consider the following. and it would be under number 6, studying the viability of a state-level student loan forgiveness program for licensed mental health clinicians, including licensed LICSW, licensed psychologists, licensed family therapists, and licensed mental health counselors. Thank you very much for your consideration.
Thank you. Very good. And we would love to entertain questions, but we're going to restrain ourselves. But we are, and just so folks know, we are very familiar, I think, with the areas that you all will be talking about, and we greatly appreciate your taking the time to share your thoughts with us. Thank you. And we're going to move on. So both Lynn and Michelle, thank you both for being here. And we can reach out as needed for clarification. So we're going to move on to Jessa Barnard of the Vermont Medical Society. Thank you for being here.
Thank you very much. Good morning. Thank you for giving me the opportunity to testify. I am Jessa Barnard, the Executive Director of the Vermont Medical Society. We represent physicians and physician assistants from across the state in different specialties and employment settings. I wanted to start my testimony with a little bit of framing of how I see S120 and S132 and the different goals of the bills. We really see the distinction between healthcare coverage and affordability issues, which we see S120 primarily addressing, and then payment reform and delivery system reform, which our all-payer model and ACO are working on. And we see 132 as working on largely elements of that with a couple coverage provisions. And I think some people's frustrations and the testimony I've heard on frustrations with the all-payer model is that it's not really designed to change health coverage. That's not the purpose of an ACO or the all-payer model. So the Medical Society supports the intent of S120 and looking at changes to coverage, expanding coverage. But I think that's important to just keep in mind that we really need both elements, that we probably can't expand coverage in the way we would like if we're not also addressing payment reform and restraining growth in healthcare costs. So we need both, but there are different tools to work on those two elements of health reform. So on 120 specifically, we do support looking at affordability of healthcare. The Vermont Medical Society, actually since 1992, has supported universal access to comprehensive and high quality healthcare, with the intent that it focus on investment in primary care, reduced administrative burden, and public health interventions. We share the frustration that patients experience when they can't afford recommended plans of care or can't seek care in the first place due to out-of-pocket costs. I would like to support what the healthcare advocate said regarding 120 and what I think you'll hear from Voz later today, which is that there is amazing opportunities right now for Vermont to make healthcare more affordable under ARPA. And while we support looking at healthcare affordability in other ways as well, we really don't want to lose sight of this opportunity that the state has right now and making sure that Vermonters know that their healthcare may become more affordable already. That's actually one of the largest issues that we hear of as providers is the out-of-pocket costs for the cost of commercial care on the exchange. And so we actually think there are tools happening right now that will really address a lot of that. So we want to keep the focus on that. We do also have two recommendations if S120 moves forward. Again, keeping these two separate buckets of payment reform and expanding coverage, we think including the language around the study of the all-payer model is a little bit of a distraction from helping Vermonters afford their health care. That could take over the entire work of this commission. It is being extensively studied already. You've heard testimony about that. There's a federal analysis going on. So we don't want to lose sight of the piece around affordability for Vermonters. And so if there is going to be an element of payment reform that's incorporated in this work, we suggest it's bigger picture, to the point I made in the initial part of my testimony, that it's a review of the role of payment and delivery system reform in minimizing healthcare cost growth and how that works together with coverage reform. Because again, we think you need both, that it's not a one or the other. You need payment reform if you're going to potentially be looking at expanding how many people we're covering or how we're covering them. Second, you've heard from a number of witnesses regarding 120 that simply having healthcare coverage does not translate into access to healthcare. coverage. For example, Patrick Flood, I really supported his statement that basically the coverage is no good if you can't get in to see your doctor or if there aren't enough primary care clinicians in the state. We know you've heard from a number of primary care providers already this session about how they're struggling under the current Medicaid program and the rates the Medicaid program pays, which is why we've actually been talking to your committee and asking for increased primary care rates in Medicaid. We really think it's crucial if you're looking at expanding public options for health coverage, what those payment rates and program design options look like that would ensure fair and sustainable payments for healthcare providers and that provide patient access to care, especially primary care. We don't think you can look at expanding access without looking at what that access would look like, both for patients and providers, to make sure that it's meaningful coverage and that we don't actually unintentionally lose healthcare providers and primary care providers based on what that program looks like or the rates in that program. So those are my comments on 120. I will shift to 132. I will say I have not looked at the new draft yet, so I don't know which elements are carried forward. I'll keep my comments somewhat high level. There are more detailed comments in my written testimony, which I submitted. The two elements of 132 that we do support are the expanded hearing aid coverage, which was section 12 of the original bill, and the eliminating of cost share for two primary care visits in section 19. There was testimony last session in the Senate Finance Committee on expanding access to primary care. I won't repeat all of it. We have some comments in our testimony about the importance of access to primary care services. I've also submitted a letter, I hope it's on your website, from Dr. Harrington and some other physicians and hearing providers at the UVM Medical Center in support of hearing aid coverage. So hopefully you have that in front of you. We are concerned with unintended consequences of several other sections that were in the bill. I think I will, again, they're in front of you in writing. I will skip to just mention the piece about provider rate and contract review. We fully support fairness and equity in contracts between insurers and clinicians. We do have concern that the submitting every contract to the Green Mountain Care Board for review inadvertently gives even more power to insurance companies who would have more staff and capacity to shepherd those contracts through a Green Mountain Care Board review process. We've suggested, if this is an issue the committee wants to continue to explore, replacing a contract review regulatory process with the ability for small practices to more effectively work together in negotiating contracts and rates with insurers. That would be an amendment to existing statute that allows healthcare provider bargaining groups currently only with public payers as opposed to private payers. So that's our one language suggestion. And again, I hope you have some time to look at our other testimony on other sections, but not knowing which have been carried forward, I will skip those details for the time being.
All right, thank you. And you have very specific comments on 132 as well as 120, so that is very helpful. Thank you.
Thank you.
All right. So we'll move on to Heather. Is it Heather Reimer? Heather Reimer? I'm sorry, Heather.
All right, no worries. No worries. So I'm Heather Reimer. I'm the director of AFT Vermont. We represent 5,000 healthcare and higher education professionals in Vermont, members in every county. And I just want to focus on, I guess, briefly two things. One, and I know you all know, but I think it bears repeating. Our members who are healthcare workers see the personal costs of Vermonters delaying healthcare because of the costs and the tragedies that can come out of that. And I think that's something that we have to, I know you all are, but I think it's worth repeating to keep that at the forefront of our mind. And delayed care often is more expensive for everyone. And obviously there are some real personal tragedies from that. The other piece of testimony I would just like to say is that the sort of wasteful, bloated healthcare system is a burden on employers. One of the things we do is we bargain, right? We bargain with our employers, and we happen to represent members who only work in the public sector and for nonprofit hospitals. And it keeps wages down. It makes the budgeting hard for employers, and again, especially for nonprofits and state and public employers. And it'd be one thing if all of that money that we're all putting into the system, we're going to provide the best care possible. But, we know that we pay more and get less health care than most countries. And, there's a lot of waste and bloat in the system, some of which we can control, I think, in Vermont, and some of which we can't. Pharmaceutical companies is more of a federal level piece. But, I'm really hopeful with this new administration in DC that there may be opportunities for Vermont to move forward on that and really create, our members have ratified, we want the full thing. We want nobody, you pay through taxation for healthcare and you don't pay a penny when you go to the doctor. I know it's going to take some time to get there, but we think that S120 is an important step toward that and appreciate the work that you all are doing on that. But again, we think there's opportunity here to move forward, to advance the case. And I think we could be strategic and ready for it. So we support the bill and continue to look forward to working with you all to bring high quality healthcare to everyone. Thank you.
Thank you. Well said. All right. Susan Risden is here from Health First. So Susan.
Good morning. Thank you. I will be brief because I know we have limited time, but I will first off say that I have to agree with almost everything that Jessa had to say. So I'll just put that out there. Regarding S120, and for the record, I'm Susan Ritson from Vermont Health First, Independent Practice Association representing physician-owned practices across Vermont. We do support S120. We think affordability is a critical issue, as is the shortage of healthcare professionals. Well, Jessa's point is very on point regarding the all-payer model having a different goal than affordability per se. We do think an evaluation of the all-payer model is prudent. I know there's some evaluations going on. There are some concerns that the evaluations may be biased toward finding a positive outcome for the all-payer model. So we do have some concerns about that. And we think that the state is uniquely positioned to look at other alternatives, especially given the change in the federal administration. And we have the opportunity to be, try novel, unique approaches. So moving on to S132, I also have not seen what has been carried forward. I will say that we support many of the presumed tenets of S132, such as transparency, fairness, and increased access to primary care, as well as hearing aid services. We do have some concerns about how the bill proposes that we get to some of those things. For example, really appreciate the fact that you're looking at, the ACO administrative salaries. However, we think linking the salaries to the primary care physician might miss the mark and make it difficult to recruit the skill set needed to make an impact as far as the ACO, as well as potentially limiting the attractiveness of Vermont by other ACOs or entities who want to do business in Vermont. And we think competition is needed. So we think it's more important that whatever model we have is able to show a clear and measurable positive return on investments. Vermonters can actually feel what the model is doing, and that if we can see a positive effect, that's money well spent on the salaries. Regarding the contracting provisions of the bill, we definitely appreciate the attention to this matter. We do support a system that distributes our finite healthcare dollars in a transparent and fair way that isn't dominated or ruled by market dominance. We think that the bill's aim to have the Green Mountain Care Board look at every contract might be trying to get to this. While we applaud this presumed attempt, we have concerns that that's not practical. And like Jessa suggested, we think provider bargaining groups, the ability to negotiate with payers might be a more practical way to get to that, or even requiring basic contracting guardrails. On the issues of price transparency and market dominance, we believe that legislature and perhaps the Joint Fiscal Office over the summer can take a look at the price transparency data that is now out there, mandated by CMS of the 300 shoppable codes. And the Green Mountain Care Board will be publishing a report based on VH Cares data and discharge data, and using those two data sets to help inform and direct healthcare efforts. This information has been long awaited, so let's use it. Also support the provision related to inclusion of specialty care and healthcare reform. That's been missing and important. And we also suggest that there's some language that directs the ACO or other healthcare reform effort to encourage the use of lower cost sites of care when appropriate. That doesn't seem to be happening now, and Vermonters are paying for hospital prices for care that doesn't need to be delivered in a hospital. Lastly, we strongly support the provisions related to hearing aids, as well as the cost share elimination for primary care visits. As you know, the out-of-pocket costs can be a barrier to people accessing primary care, which can lead to higher costs down the road if they're delaying care. Like Jessa mentioned, we do have concerns that our primary care network is already strained and needs to be bolstered before we can just assume that they can handle this. These visits. So we would like to see, more investment in primary care in the way of, as we mentioned in previous testimony, increased Medicaid payments, loan reduction or debt reduction, scholarships, and decrease of administrative costs. So in summary, we support the tenets in the bill. In my written comments, we'll have more details on some of the things that we suggest that you consider changing or adding. Thank you.
Thank you. That was extremely helpful, and I appreciate your comments. We're going to move on to Betty Keller, who is the president of Vermont League of Women Voters. But Betty, you sent me a little note in the chat, or everyone, that you have folks to representing different perspectives. So why don't you go ahead and introduce yourself for the record, and then introduce the folks who you have here who will be testifying.
Thank you much. So I am actually not the president of the League of Women Voters. I'm the president of the Vermont chapter of the Physicians for a National Health Program. I'm on the healthcare committee for the League of Women Voters. My name was swapped in for Sue Racanelli, the president, who deferred to me to speak on this healthcare bill.
Okay, thank you for that clarification.
And then I have with me here Marvin Malik. Dr. Marvin Malik is a practicing primary care physician. He's on the phone and trying to deal with patient care while he's getting ready to jump in here. And he'll be able to speak from a practicing physician's perspective. So I very much think that will be beneficial to you. And thank you for this opportunity to speak to you.
Thank you.
Good morning. So thank you so much for inviting us and giving us the opportunity to speak on the Healthcare Bills 120 and the S132. Today I'm speaking on behalf of the League of Women Voters of Vermont, for whom I serve on the Healthcare Committee. The League of Women Voters of Vermont has strongly advocated for Vermont to pursue a universal publicly funded healthcare system for a long time, and recently has been active in raising concerns about the lack of accountability in our accountable care organization. We are also concerned about the failure of the Green Mountain Care Board to perform the work for which it was actually created. I absolutely recognize that good people can have different opinions about how to achieve a shared mission. And my good colleague, Dr. Malik, does not share all my opinions about S120, but right now I'm representing the League of Women Voters. Some of you here have worked very hard for a very long time to try to reduce healthcare costs for Vermonters and very much want to actively be working on something to make things better. Thank you for your passion. I would like to share with you a few of the sections of Act 48 that are particularly relevant as we look at S120 and S132. From Act 48, the healthcare system must be transparent in design, efficient in operation, and accountable to the people it serves. My comment, our current healthcare system is not in any way transparent or efficient, and it has become less transparent, less efficient, and less accountable since OneCare has been inserted into our healthcare system as an additional, totally unnecessary layer of administration. I'm not entirely convinced that this study committee is necessarily a good use of taxpayer money. However, if you're going to do another study, by all means, in my opinion, this is the most important sentence in S120, which must be retained. Section 2C, the committee shall consider the following: the efficacy of Vermont's all-payer accountable care organization model and the changes to the model that would be necessary to make healthcare more affordable for Vermonters, or whether an alternative model may be more effective. It would be more efficient to cancel the ACO project, or at a minimum to not renew it. The legislature doesn't have the authority to do that, but you could pass a resolution asking the Agency of Human Services and Green Mountain Care Board to not renew it. You don't need a study to review these simple facts. ACOs are based on the idea that people use too much healthcare, but we don't in the US, and we certainly don't in Vermont. We can't afford to because we can't afford the deductibles and copays. Integration of care and coordination of care are a couple of phrases that are used to speak of the purported benefits of an ACO, but you don't need an ACO to do those things in a rural area with only one hospital and not that many practitioners. Mostly, you need to allow time in their schedules to talk to each other. That doesn't require an ACO, and an ACO may actually make it harder. What we want right now is affordability and access. This ACO has nothing to do with improving access. If you actually take money away from the services, you reduce the access. So that's why it does belong in 120. It does have to do with access as well. And there is no way they can improve affordability. The way to improve affordability is to reduce administrative costs. And an ACO is added administrative costs. OneCare is a monopoly. A single private ACO as a monopoly is dangerous. We need a single risk pool, but it must be transparent and accountable, which OneCare is proving it is not, and it will fight. Several private ACOs with defined geographic borders and monopoly within the borders of each carry the same risk. Multiple risk-bearing entities competing on the same turf cannot save costs because they will be spending money trying to compete. They will be lemon dropping and cherry picking if at all possible. They will be gaming the system for billing. They will be increasing administrative costs and reducing quality of care because of the nature of the beast. And in a rural area, this competition would only fracture care instead of coordinating it. From Act 48 again, primary care must be preserved and enhanced so that Vermonters have care available to them, preferably within their own communities, and that these health services be sustainable. When you talk about payment reform or value-based payments, the payment reform that is really proven, used in multiple countries that spend far less on healthcare, is global hospital budgets. Global budgets could also be used for other entities like clinics and long-term care facilities. But what the Green Mountain Care Board calls global budgets are actually imposters. I urge you to get a 5 or 10 minute lesson on what they really are and teach it to every rural hospital administrator and CFO in the state, and you will see a huge difference in the attitude of rural hospital administrators toward a system that actually used them. That could be a good use of time while the study committee is speaking with stakeholders. From Act 48 again, Vermont's healthcare system must include mechanisms for containing all system costs and eliminating unnecessary expenditures. The mechanism to remove the most obvious unnecessary expenditure and source of excess cost growth would be to eliminate OneCare. I'm particularly alarmed at having heard that we won't be able to test the model because expenditures related to the pandemic will throw the data off for not just 2020, but for 21 and 22. I'm flabbergasted that this state of fiscally responsible citizens would commit to this project under these circumstances. That we would sacrifice needed services like addiction services so that rural hospitals can pay their fee to the ACO is astounding to me. Again, from Act 48, the financing of healthcare in Vermont must be sufficient, fair, predictable, transparent, sustainable, and shared equitably. There will be disruption someday when we transition to a national health program. I was disappointed that on a federal level, so little was done to deal with the healthcare crisis while we were already moving money around to help companies, families, states, and communities weather the economic impact of the pandemic. That would have been the perfect time to take up the federal Medicare for All bill, but here we are. In Vermont, we are looking at how to use some of the money to help people pay for their health insurance. In S120 Section 2, Powers and Duties, the committee shall explore opportunities to make healthcare more affordable for Vermont residents and employers, including identifying potential opportunities to leverage federal flexibility. And then in Section 5, you talk about opportunities made available by the Biden administration to expand access to affordable healthcare. I urge you to add, or through pursuing other programs with a state innovation waiver through Section 1332 in the ACA. So here is where the public hearings come in. As long as you were traveling around the state, what are the most productive ways to use those hearings? Number one, teach what ACOs are. Most people can't even begin to understand what they're doing. What is their maximum potential? What they can't possibly do, how much they cost, and where the money goes. Have a doctor present to talk about coordination of care in that local area, how well it works, and how one care makes or doesn't make a difference, and how it could be improved without one care. Then ask members of the public for their input and make their thoughts loudly and clearly known to the Agency of Human Services, the governor, and the Green Mountain Care Board before the contract is considered. Before you go on this tour, decide what innovation waivers you want to pursue and be ready to gather the needed input for your application. There's a strong urge to do something, and there is this feeling that you have to pursue the ACO because you don't have anything else to try. First, do no harm. Sometimes a patient will get better from a useless intervention due to the placebo effect because you were nurturing them, but bloodletting, for instance, was doing harm. ACOs are not a harmless intervention. Even if you don't have a plan B, it is better to abandon this plan A. Thank you so much for your time.
Thank you for your comments. So we have with us
Marvin Malik.
Marvin Malik, and you, is there anyone else who will be speaking from the League of Women Voters? But I think you're
No, I'm the one speaking for the League of Women Voters.
Finally got it.
And Marvin has connection issues. There he is. There he is. Okay. Marvin, you're
Dr.
great.
Malik, thank you for being with us again. We greatly appreciate it. And if your audio starts to go, sometimes it helps just to turn off the video. But we'll leave it to you. And please do go ahead, introduce yourself for the record, and provide your testimony. Dr. Malik? Dr. Malik, can you hear me? Send him a note.
I'm calling him. It looks like he's doing paperwork with his.
It looks like he's doing some administrative work.
Yeah, I'm calling him.
We'll just wait 1 minute.
There's a phone number in the waiting room ending with 271. Is that Dr. Malik by any chance?
I'm not seeing it.
It went straight to voicemail, so I didn't get him. So,
Oh, I'm sending him a note.
What did you say the number was in the waiting room? Because he often uses a phone at the same time that he uses the computer, and he may be trying.
Can you hear me now?
Yes.
Yes.
Great.
Yeah, sorry for that technical problem on my work computer. Anyway, my name is Marvin Malik. I'm been a longstanding member of Physicians for National Health Program and for 20 years, the Vermont chapter. And I'm testifying today I'd like to talk both about cost control and also about the impact of OneCare and potential ACOs in general. And I guess I'll start out talking a little bit about cost control. I think there are limits to what an individual state can do. We are unable to get rid of many of the external sources of funding because over 50% of the funding of our healthcare system comes from out-of-state sources. This adds to tremendous administrative complexity dealing with workers' comp, auto injuries, Medicare, federal workers, people in the Adirondacks who use our care, people from Florida who are coming up as tourists or coming up as snowbirds. So it's very difficult for us to reduce administrative costs, unfortunately. However, there are some administrative costs that could be reduced. The one that makes my blood boil at a less than 212 degrees Fahrenheit boiling point is constantly listening to advertising for elective orthopedics by multiple hospitals. And I think that the state legislature should make it clear, both to the hospitals and to the Green Mountain Care Board, that wasting money on advertising is not something that we're going to countenance, and that one of the more effective cost control strategies that we have and should continue is Green Mountain Care Board regulation of hospital budgets. And I think the amount of administrative expense, including advertising, lobbying, high CEO salaries, should all be factored in the percent increase or hopefully decrease in hospital budgets each year. So I think the legislature should find ways to make its opinion known on those issues. There are a few issues that are also largely internal to the state that the state could work on to achieve cost control. One is doing all it can to reduce spending on medical malpractice. That is basically an entry of money into the healthcare system that providers and hospitals have to cover that does not end up leading to any medical care. It also does not improve care. And the biggest single intervention that could both reduce errors and improve care is having a seamless high quality software system that we all share. So that intervention, I actually spoke 9 years ago with people from the Green Mountain Care Board, but they didn't feel empowered or able to take that issue on, to create a single seamless software that everyone in the state and ideally the country would be able to use. And I understand the reasons for that, but I just want to point out that if you're looking to improve quality care and reduce costs, that would be one of the most powerful interventions. If we had a national single payer system, that would get this whole albatross off of our backs. And there is a resolution for state and local governments to support a single payer system nationally. And this will not cost you any money to say that you support it, and I will mail it to you. And so that you can see the resolution, and I hope that you'll pass it to indicate to the federal legislators that we want a single payer national program passed. Short of that, I think working on reducing administrative costs, the ones we have control over, would be some of the more effective interventions. The final intervention that you could work on, and I actually strongly recommend you do, is the cost of recruiting. That is an internal cost within the state that we can control, and we are getting creamed. Small hospitals across the state and really across the country are getting creamed on recruiting costs. I don't know if you're aware that recruiting firms, when they succeed at placing a doctor, they charge, say at a hospital practice, which is the usual situation these days, they charge $40,000 as a fee. And I feel like if the state government could expand its AHEC program, which is very limited and deals mostly with in-state medical students, if they expanded that to a more general recruiting effort, create a website called Vermont Healthcare, vermontprovider.com or something like that, vermont.gov for recruiting, and follow up leads, hire a couple staff members. I think that would be an intervention. It wouldn't be as grandiose as what you're looking for, but you have the potential to control costs because these $40,000 outlays start to build up when there's enough of them. I also think that reducing state spending on what is not working very well would also be another plan. And Vermont Information Technology Leaders is a program that's been going on for well over a decade. I've never used it, and I don't know a doctor who has. I've never gotten a single bit of clinical information using anything, what they have developed. I don't know what they have developed. We get all of our information from Dartmouth and UVM and other facilities via fax machines. They're then optically scanned into our record. So whatever payments have been going on to that seem to have produced little utility. Similarly, the OneCare is an organization. Someone asked me, well, how does OneCare impact your practice? And I said, I don't know that there've been any impact one way or the other. I don't know of anything they've done. So they're supposed to be helping with coordination of care, but if I want to talk to a pulmonologist or a rheumatologist or another primary care doctor or a doctor in Florida who was taking care of the patient, last week, when they were down there, a patient was down there, none of that happens. And so I asked other people who might be impacted by OneCare. I asked the care coordination team at our hospital, and they are funded to some extent by OneCare. If they enter their data elements into the software that OneCare provides. So the software that OneCare provides has the advantage that it actually connects with all the other people involved with mental health patients who need a lot of services, which is an important population. So that's good. And so that might make you think that this is a great intervention, and it's fine. I certainly no objection to all that. I can say, however, that we had the same care coordination team, it's really the same people doing the same work before there was OneCare. It was back when there was the Blueprint for Health was primarily involved, and that's when it got going. So it was continued, but now funded through OneCare. Whether all of the administrative costs through OneCare are needed to get us the care coordination team is another question. I think it is not. And the other issue is that I have no access to any of the information that's in their software. So the people who do care coordination have to make two entries. One is into the software that I could see in our primary care practice, and the other is this software that OneCare has developed. So you can start to see the issues with wasting time and software incompatibility. So that's sort of coordination of care. I see them as fine. I don't think it's greatly innovative, but to the extent that coordination of care for mental health patients who need a lot of services, to the extent that that's happening, that's certainly a good thing. How much we should credit OneCare for that is another question. In terms of whether OneCare is likely to save money through prospective payment or abandoning fee-for-service, that's very problematic because the patients are attributed through primary care while there's the money that you're spending is primarily in specialty care. And we don't really have that much control over what the specialists do. And also an individual specialist has a strong motivation to do more, even with OneCare's negative incentives. Because if they're going to get paid $16,000 to do a procedure and then get penalized for every procedure they do, they might lose $20 at the end of the year. You can see where the incentives lie. And so I think it's going to be very problematic. The fact that our main referral hospital for Southern Vermont is in another state makes it more difficult. So I would be, and then OneCare has high administrative costs inherently. It's not particular to OneCare, it's what an ACO has to do. So I'd be fairly pessimistic, and it's going to be also very difficult to evaluate the efficacy of OneCare. Comparing Vermont's spending rate of cost inflation, health cost inflation to other states would be one way, because most other states aren't very far along either for all these same reasons. So I think you may want to not expend money where it's not likely to help, and maybe little projects that are in state that can actually save some money, especially recruiting, might be a useful thing. And I do hope you'll support the National Single Payer Resolution. You will be we haven't put it we haven't done very much to get state governments to do it, but I think if Vermont leads the way on that, it would be fantastic. Thank you very much for all your work, and I know how hard you're trying to improve care for Vermonters.
Thank you, Dr. Malik, and I know how hard we know how hard you have been working on this for many years, and appreciate your comments. Thank you.
You're welcome.
So we're going to move on to Vicki Lohner of One Care Vermont. Where are you? Here you are. Okay.
Here I am.
Thank you for being here. And there was someone in the waiting room calling by telephone. So I don't know, it may have been Dr. Malik, I don't know, but now they've hung up, so I won't ask again for folks who are here if you know who that was. So Nellie's put a message up on chat. So, okay. Thank you for being here, Vicki, and we look forward to your testimony.
Great, thank you so much. So for the record, Vicki Lohner, CEO, One Care Vermont. And I want to thank the committee for the opportunity to testify on behalf of One Care and its participating providers who, as Jessa pointed out so eloquently, really are committed to helping to change both payment and delivery system reform. And so that's the primary goals of the ACO that were set out under the all-payer model. In regards to S120, I do believe that that has to do more with financing and less about the delivery system and payment reform efforts. What I'll say about the additional evaluation of the all-payer model is in the terms of the agreement between CMS and the state of Vermont, there was a very good evaluation framework set up that looked at cost, quality of the model being performed by an independent evaluator, which is NORC out of the University of Chicago, who has fairly extensive experience in both qualitative and quantitative analysis of such models. And it's my understanding that their evaluation of years 1 and years 2 will be out later on this fall, that there was a delay because of the pandemic and that work, because it does require them to do interviews with providers throughout the state of Vermont to get their perspective on the model. And so knowing that providers have been really busy caring for patients during the pandemic, there had to be a pause in that. So I would say that adding additional layer of evaluation is unnecessary in terms of S120. I would also note that the all-payer model improvement plan that was put out earlier this year by the Agency of Human Services has a lot of nice steps in it that can be taken to provide some continuous evaluation and improvements to the model as we move forward, so as not to have to wait for the NORC evaluation. I think there's a lot of good work that could be done in between. In terms of S132, I would of course say that we are in support of hearing aids, primary care support, and moving the innovation oversight to the Director of Payment Reform. There is a tension between having the Green Mountain Care Board be both the innovator and the regulator. So I think that just makes good sense to have that transition to the Director of Payment Reform. In terms of the other aspects of the bill as it relates to the ACO, we generally oppose all other aspects of the bill. What it really sets up is a system where it is diminished capability of provider-led payment reform. And that's what this was set up to do. That's what the ACO was set up to do, was to really be provider-led payment reform. And it transfers essentially all management, operations, and decision-making to a very small regulatory body that is not set up with the right expertise to do the work. So I would say if the goal was to increase engagement in the model, this bill as written, and Madam Chair, I have not seen the updates. So maybe many of this has been addressed, but it does not support provider-led reform. And I feel that what will happen is that providers will not engage anymore. And that would be particularly unfortunate, given that even during a pandemic, we had an additional community, Rutland, join because they are so committed to this model and to the work that the state is trying to do. So I would hate to see engagement go down, which would further put us in corrective action with the federal government as a result of this. I would also say that there's a lot of additional administrative burden and oversight put in this bill that's unnecessary. The ACO has fairly rigorous oversight by the Green Mountain Care Board, by all of its payers. The ACO, of course, has to have oversight of itself as an entity. We have an independent financial audit every year from PwC. We have a compliance audit every year from an independent auditor. So there's lots of structures set up in place within the ACO. I'm not sure what the auditor's office would be able to do in terms of adding value, aside from adding additional administrative cost and burden to the ACO and the system. So, and I would also say that opening up access to all participants that are part of the ACO to the auditor's office is going to make further engagement with provider participants particularly hard. So as we look to how we move forward with this, I would say that, again, the state has put forward a really nice framework under the all-payer model improvement plan. The recommendations in there in terms of really moving insurers to true payment reform, such as the federal government, which is a big player in this, would be well worth the effort of this committee to look at how steps could be taken to improve and move that forward more quickly for both the federal government and for commercial insurers. Currently, Medicaid is the only payer in the state of Vermont that is offering true fixed payment reform under this model. So I think others could really learn from the work that they've done. I also want to appreciate the work of this committee in House Healthcare and Appropriations and the Agency of Human Services for making those investments in programs like Dulce, the home health, longitudinal care, and care coordination programs that support providers on the ground. The ACO has not set up an internal centralized structure to do that. That's really helping the delivery system to make those changes and reforms that will be necessary to be able to be paid under a different structure. So I think that would conclude my comments. I have submitted written testimony as well to the committee. Thank you.
All right, thank you very much. Yes, we do have your written testimony on our webpage, and we'll go through it completely. Thank you very much.
Thank you.
We have Devin Green of Vermont Hospital and Health Systems. Oh, you're sitting right there. I'm looking all over my screen for you, and you're right there. This is the problem with Zoom, you know, in the committee room, Vicki would get up and walk over to her seat or her standing area, and you would take her place. But so thank you for being here, Devin, and we look forward to your testimony.
Thank you. Devin Green, Vermont Association of Hospitals and Health Systems. Thanks for having me in today. I am going to quickly go through S-132 and our response to that, S-120, and then I have a little proposal that I'm going to throw out there because it's really important to our hospitals, and I apologize for it being last minute, but it's important and has come up recently, and so I'm putting it out there. So to start with S-132, I saw that these provisions were no longer in the proposed bill, but I want to address them anyway because the overall concept of the bill goes towards healthcare provider delivery, and it creates a lot of instability and unpredictability in the healthcare system. So one thing that the bill was proposing was changing healthcare delivery system reform from provider-led and evidence-based to shifting funding, having the Green Mountain Care Board shift funding around. So to a state-based regulatory exercise by a small panel without clinical expertise. And this creates a lot of unpredictability in our healthcare system, these proposals. We saw the unintended consequences of shifting healthcare dollars when the legislature cut DISH funding to hospitals in fiscal year 2018 and redistributed it to the designated agencies in an effort to reduce wait times in emergency departments for individuals in mental health crisis. Today, ED wait times are longer than they were a few years ago, and in the meantime, that DISH cut directly contributed to Springfield Hospital's bankruptcy. So the idea of taking healthcare dollars and moving them from one place to another is deeply concerning to our fragile hospital system. And it comes up every year. And so they are in this complete state of instability. I talked to a head of a primary care organization who said that he is trying to decide between investing in EMR and investing in population and health, and he's leaning towards investing in EMR because it's a safer bet. Why should he invest in population health when the sands keep shifting in healthcare reform? So I just want to put that out there in terms of the instability that the proposals in S-132 create. I also want to say that I saw that the audit of the ACO is in the new draft, and VAS does not support the audit of the ACO. The auditor's office already did a report through the Green Mountain Care Board's oversight of the ACO, and so this would be redundant. And we also can't support auditing non-government organizations. It really opens the door there and creates a new precedent that we cannot support. That being said, there are pieces that we do support in S-132, including the hearing aids, the 2 primary care visits, and the DMR reform, and also moving the reform pieces of the Green Mountain Care Board over to the Director of Healthcare Reform. So those are my thoughts on S-132. Moving on to S-120. This bill I see is really supporting immediate affordability for Vermonters. What we've been hearing in the testimony time and time again is Vermonters have high premiums, they have high out-of-pocket costs, it prevents them from accessing care. They need immediate relief now. And we support efforts for affordability for Vermonters. We've seen an uptick in uncompensated care, which indicates a clear problem, and it leads to bad health outcomes for Vermonters and makes our rural hospital system more fragile. So we support affordability for Vermonters. We want to see S-120 done in a really direct and focused way, so those Vermonters will see relief immediately. And I think the best way to do that is to build off of the previous work on affordability that this body and previous administrations have done. So we have the single payer report. We have 5 reports on the universal primary care. We have, I was dismayed to see that this new group would look at expanding Dr. Dinosaur, because we did a 2017 report on expanding Dr. Dinosaur, and we found out that it would increase adult premiums by $1,000 a year. And so it really looks like this is a group that's starting from scratch and not building off of previous efforts. And in that, I think that will just increase the amount of time of making headway on this and not give Vermonters the affordable care they need. So please work off of previous efforts and not do redundant efforts. That being said, if we're looking at affordability, the all-payer model and the ACO is not about immediate affordability. It's provider delivery system reform. It's designed to reduce the cost of the healthcare system over the long term by employing preventive services today to create better health outcomes for tomorrow. So while it is making measurable differences for the child in mental health crisis who can now go to the psychiatric urgent care for kids instead of the emergency department, while it's making a noticeable difference for the food insecure diabetic who benefits from greater coordination of care, it's not going to change people's premiums or out-of-pocket costs overnight. So in terms of focusing your efforts, I think it makes the most sense to get regular reporting on the progress of the implementation improvement plan that AHS has done. So there's an oversight by the Green Mountain Care Board, there's an oversight by the federal government, and AHS has this implementation improvement program. If you're looking for accountability for the ACO, have AHS come in and report on the progress that's happening through the implementation improvement plan. Don't restart from scratch on some separate study looking at the ACO when really you could focus on other things that will make Vermonters' lives and healthcare more affordable going forward. And I think the main thing there are all the incredible opportunities under ARPA, the American Rescue Plan Act. So that act is going to significantly bring in a lot of subsidies for Vermonters. It takes the former benefit cliff where people got subsidies up to 400% federal poverty level, and it totally smooths it out so that people are getting subsidies up to $76,000 for a single individual. So if you're an individual making $76,000, you'll get subsidies through the exchange. If you're a family of four, you'll get subsidies up to $157,000. No one's going to pay more than 8.5% of their income with these new subsidies. That leads to a bunch of questions. So if you have a lot of subsidies going into the exchange, should people drop their healthcare coverage or not? Sorry, people should not drop their healthcare coverage. But do we want to look at
that was a test. We were listening.
Do we want to look at having small employers drop healthcare coverage because people will have affordable healthcare in the exchange? This leads to other important questions. Like, this is particularly important for healthcare reform moving forward, because when you apply for a 1332 waiver to do single payer or to increase the age limit for Medicare or to do any of these options, what they look at is how much you're receiving in federal dollars through the exchange. And they take that money and they lump it to you and they give it to you. So you want to have a strategy where you are maximizing your federal dollars through the exchange and maximizing your federal subsidies. So these are all really important things to look at. Other things to look at is we have a premium assistance program. That's $5 million. That's additional to what the federal government provides. What do we want to do with that $5 million? Do we want to subsidize other income levels? Do we want to subsidize cost sharing? What do we want to do with that? And then in terms of the primary care visits, one thing that we keep running into when we look at covering primary care is the HSAs, so the health savings accounts, and how they do not allow for coverage until you meet your deductible. And so that's always a barrier, and that should be looked at too. So I would say for S120, instead of going broad, go big, but go effective. You know, we know that Vermonters need affordability relief, and so make it happen. Line yourself up so that it can really happen this time instead of starting from scratch. The other thing I would do is work with DEVA on these on these public hearings that you're going to have. Vermonters need to know there are people in the 400 to 600 federal poverty level who don't know that they're eligible for these subsidies. Go to them and educate them about that. Make sure that they know the opportunities that are available to them through ARPA. So I would just ask this committee to make this, I think this study is important. I would ask this committee to make it really useful and really focus on healthcare coverage affordability. One other opportunity, if I may, sorry, is I think in the delivery system reform piece, there is an opportunity to look at care coordination. So the OneCare has care coordination, insurance companies have care coordination. Where is there overlap? Where can that still be streamlined, but give you the efficacy of care coordination and good health outcomes? That would be another opportunity to sort of reduce the costs. So that's what I have on S120. And now is just my quick pitch, totally shifting gears to pharmacy benefit managers. FQHCs and hospitals have been dealing with attacks on the 340B pharmaceutical program, which provides subsidies for hospitals and FQHCs to keep their doors open and do programs. And we've seen Express Scripts recently require this burdensome reporting requirement. And we are asking for some protective language that can also be found in Utah that would prohibit pharmacy benefit managers basically from creating additional requirements or restrictions on the 340B program. And that's what I have.
Thank you. I know that Utah had done that, and I know that when I've met with folks from Utah, they're very active in pharmaceutical coverage costs. So thank you for that. That's new. Okay, and that's in your written?
Yes, at the very bottom.
At the very end. Saw it. Okay, thank you, Devin, and we're going to keep moving along. We have other folks added on after Steve Howard. Steve, I hope you are here. Yes, he is. Thank you for being here. Why don't you introduce yourself for the record, and we'll listen to your testimony.
Thank you, Madam Chair. Thank you for members of the committee. I feel well represented in this committee because I have my actual senator, Senator Cummings, and my two honorary senators, the Rutland delegation, who are here in full regalia here for this testimony. I just want to start with a strategy that has worked pretty much throughout my life, because you've been hearing from some very smart and well-versed folks on the issue of healthcare. And so I want to just lower expectations for what I'm going to say, and just let you know that I am the spokesperson for the members of the Benefits Advisory Committee of the VSEA, who are much more immersed and well-versed on these issues than I am. But I did consult them about this bill, and they did have some points that they wanted to make. The first thing I wanted to say is that the state employees healthcare plan is perhaps a model. The plan is negotiated as part of collective bargaining and is managed. It's a self-insured plan, and it is really managed. The practical everyday management of the plan is through Blue Cross Blue Shield, but the decisions about the plan are really made at the bargaining table, where the workers and the management have equal power. And also it's overseen by a collaborative effort of labor and participants, the administration, the members of the VSEA, and the members of the retirement community work together throughout the year to make advisory decisions and to consult on the operation of the plan. And that plan is one of the best plans in the country. It has some of the lowest costs in the country. And in fact, this year we are in the budget going to have premium holidays because of the massive amount of surplus in the plan. So I just want to make that point, because when you have a collaborative effort like that, you are able to manage the plan in the way that the state employees plan is managed. So it is a good example maybe for healthcare cost containment throughout the state. Our members wanted, we are now, as of this fall, our members' lives have been attributed to the Accountable Care Organization, OneCare. It was not the choice of the members of the VSEA to be attributed to OneCare. It was out of our control and unilaterally decided by the administration. It was not a decision that we supported. Our members, I think, would stress what some folks have said is that the ACO is not healthcare reform, it's payment reform. Our members feel that there's not enough data around the ACO to know whether it's being effective, and the transparency really needs to be improved and increased. And our folks really believe that this model should be scrapped and that we should be looking at a model that'll cost something less than $20 million in administrative costs. They think basically this is the wrong approach, and that really, if you want to contain costs, and the state employees plan is an example of this, it's all about access and increasing access, making it less costly, making it more available, which really means lowering out-of-pocket costs, increasing universal coverage, and using tax revenues to do that. Rather than limiting the services that are provided to folks. The other important part that our members wanted to discuss, and it's clear in places like Rutland and other rural communities and throughout the state that we don't have enough healthcare infrastructure, not enough primary care physicians, access to nurse practitioners or specialists that would get people the right care at the right time and reduce their dependence on more expensive care. The only other point, I think, a couple points folks wanted to make was that it's really important that the consumers, that organized labor, be included in any study committees that you have, that it's both in terms of just their experience, which is with our healthcare plan vast, but also in our ability, to Devin's point, to get the word out about what's out there in the broader marketplace beyond the state employees health insurance plan. There is a lot of infrastructure there. And the only last thing I just want to just a quick plug in, and I know this is part of S-132, is that our members are strongly supportive of the coverage for hearing aids that is included in that bill. So those are just the brief points that our members asked that I make. If you have any questions, I'm happy to try to answer them. I probably will defer to people who actually know more about what they're talking about than I do.
Thank you very much, Steve. This is very helpful. I don't see any written testimony from you on our webpage, so if you have that, it would be really helpful to send it in to Nellie.
We will do that. Thank you.
All right. Thank you very much. All right. We're going to keep going. We have two more people who are here with us. Helen Laban of VPQHC, FQHCs. The Q always gets me. Thank you for being here, Helen.
Thank you. So I'm Helen Laban. I am the Vermont Public Policy Director for Bi-State Primary Care Association. You do have written testimony from me on S-120. It is succinct for me. It's shorter than my average email. And I won't restate that here. It does speak broadly to our perspective on payment reform, healthcare delivery reform, and payer reform. To follow up on points that have been made, I think you've heard it clearly that the idea that direct and immediate reduction of insurance costs and affordability for consumers is not a goal of the all-payer model, nor should it be. They're connected, but they are in many ways apples and oranges. And we agree that there should be focused legislation and policy efforts to directly reduce those insurance costs for Vermonters. We do not believe that S-120 necessarily achieves that as currently presented. I did not do a close line by line and suggestion for other options in the way that VAWS has done. However, I'd be more than happy to crib off of their work and review that testimony and provide additional line by line ideas on behalf of Bi-State if that's something that would be helpful to you. So kudos to Devin for being very constructive in that way, and I can replicate. I do want to make a quick point that I think has come up a little bit, but not been as strongly stated as FQHCs feel it. So we are federally qualified health centers. The federal part of that is key. We do provide healthcare, primary care, and preventive care access to about 1/3 of Vermonters through our membership. And we also provide access for about 45% of Medicare beneficiaries. We strive to be highly responsive to our local communities, to be innovative, to do a range of services and to reach the most vulnerable Vermonters. That being said, we are both funded and regulated by the federal government. So we don't have an option to move forward on healthcare reform that is not in alignment with the federal government. And that's really what the all-payer model allows us to do. It brings in our federal partners into Vermont's healthcare reform initiatives and lets us all move forward together. We don't want to be in a point where we have to choose between what Vermont wants to do and what the federal government wants to do. That is an impossible choice for us. We would be unable to do anything in that situation. And for that reason, it's critically important to us that the all-payer model exists and provide that alignment, because I literally don't know what we will do if we don't have that alignment. And so that's really a key and critical point. And we have heard clearly from the federal government and are told on a monthly basis that value-based payment reform is what we need to be doing, and we are contracted with to support that. So we will be forever strongly in favor of value-based payment reform and that alignment. So that's really the point that I wanted to bring home. I believe that one of my members is also on the line, and I would not take up additional time that could be spent hearing from how this is playing out on the ground. So thank you for listening to my testimony.
Thank you. And thank you for your written testimony. I think if you concur with other things that you mentioned, Devin Green's testimony, if you concur with some other testimony, whether it's Devin or others, please do let us know that. It's nice to have some triangulation along the way. We've certainly heard that from different folks. Thank you. We also have Michael Costa here. You are here. Thank you for being here, Michael. And I don't know if we have anything in writing from you.
Yes, Senator, I submitted something in writing and I'm happy to speak to it.
Thank you. Why don't you introduce yourself for the record, and then we'll hear your testimony.
Good morning. Thank you to the committee for having me here. I know you're quite busy. My name is Michael Costa, and thank you for the opportunity to testify regarding S-120 and related topics in healthcare reform. Presently, I serve as Chief Executive Officer of Northern Counties Healthcare in St. Johnsbury, which is a health system consisting of a federally qualified health center with 5 primary care sites, 3 dental sites, and an express care clinic. And we're also a Medicare certified home care and hospice agency. I also serve on the board of directors for the Bi-State Primary Care Association, the VNAs of Vermont, Vermont Association of Hospitals and Health Centers, and One Care Vermont ACO. Prior to that, as many of you on the committee know, I served as Deputy Commissioner of DEVA during the present administration, and part of my duties was to bring to life DEVA's healthcare reform efforts, particularly regarding payment reform. Prior to that role, I served as Deputy Director of Healthcare Reform for Governor Shumlin, which included being on the negotiating team for the all-payer model and working on Green Mountain Care and the universal primary care studies, among others. So, I left DEVA, even though it was the best job I'd ever had in my life, except for a summer at Carvel Ice Cream, for the following reason. After years of working on Vermont's vision for healthcare reform and time implementing that vision at Medicaid, I wanted to be involved at the point of care. That pivot from focusing on healthcare reform vision to execution has been really illuminating, particularly during COVID. And for me, it's instilled an extraordinary amount of humility. I think of the term delivery system reform really differently now, because I have a responsibility for our team, which cares for people 365 days a year. And I watch our clinicians and our nurses and our personal care attendants care for people who are frail and elderly and sometimes really scared. And that experience hasn't dimmed my belief in the need for reform, but it has made me appropriately respectful of the scope of the project. So the transition to value-based care, which I know the committee has taken a lot of testimony about, and value-based payments that would allow us to focus on how to make communities physically healthy, mentally healthy, well-housed, well-nourished, and financially secure, it requires time and trust and effective risk management. So each day as CEO, I have to decide how aggressive or conservative I want to be about transitioning northern counties to value-based care. I have to decide what portion of our time, money, and talent and my own credibility as a leader is allocated to that project. And the healthcare reform bills this session, and particularly recent comments made by the state's chief healthcare regulator, have a chilling effect on our reform efforts at the provider organization level. I'm left to wonder whether the present approach will continue or whether Vermont will find a new vision for healthcare reform, which would be our third in the last 10 years. And that uncertainty creates real dilemmas. So do I work with OneCare on a capitated payment model for FQHCs for 2022? Or do I wait until a new agreement is signed with the federal government? Do I invest in population health management, or do I take on an electronic health record project, which would take a year and quite a bit of money? Do I add more wraparound services? Because so many of our people come into our clinics and their problem primarily is not a healthcare problem. They have other issues that we need to help them with. Or do I be more cautious about that because I may lose the substantial support we get from OneCare? Do I add a clinical pharmacist because more and more of the problems that our patients have are complex pharmacology, right? How all their drug interactions work together. Now that'd be great for my patients and it would reduce visit volume, which is great in a value-based world. But do I take on that expense now and potentially be stuck in fee-for-service for a long time? And then have to wait to see what the state's next commitments are on healthcare reform. And so this is just a few of the many trade-offs that healthcare leaders have to make when thinking about the operational imperative of the present and then the transition to future innovation. And so, Vermont, in my view, is rightly viewed as a leader in thinking about creating a more just and equitable healthcare system. Yet, what I found in the transition from state government to the provider community was that policy vision is only as good as the execution by those healthcare organizations. So I would just ask the committee to consider the effect on healthcare leaders and organizations of potentially diverting attention away from the all-payer model and considering a new way forward. So that's all I wanted to say. Thank you very much for all you do for Vermont and Vermonters. And thank you for what has been a really, probably the best Zoom meeting I've had this week. You are all getting really, really good at this. So. Oh, I can't.
We
hear
were
you.
almost good. I didn't unmute myself, but I just want to say thank you. We've had a lot of practice at Zoom, ever since last March. I think the day that this committee started was March 13th or 16th after we got off the telephone. And we've been doing it through the summer, the fall, and continuing. So, but thank you very much, Michael, for your comments. It's good to see you again, and we very much appreciate your testimony.
Thank you very much.
Yeah, terrific. So I don't think there is anyone else with us this morning who has asked to testify, and frankly, committee, I think that it's time for us to close the testimony loop on this one, on the bills, and then for us to dive into some consideration of what we have heard and some recommendations perhaps for amending one or both bills. So before we begin that conversation, my suggestion is that we take a little break. It's been a very intense morning. We've heard a lot of good testimony, and I think we deserve a little time to stretch our minds and our bodies. So let's, looking at the time and what we have before us, we also have the budget memo we want to firm up. So let's take, I hate to say 15. Let's come back at 10:45. That's a 14